do him. There we go. Are we live? Right. There we go. No lag. Okie dokie. Well, welcome to today's meeting of the Leicestershire County Council Health Overview and Scrutiny Committee, which is being held online due to the current pandemic situation. The meeting is being broadcast live to the public on YouTube, and for those not able to watch the footage live, the webcast will be available for viewing soon after the meeting. Can I please ask that all officers and members mute their microphone until they wish to or are invited to speak. When you are speaking, please turn your video on, then we can see you in your full glory. I'll now go around and do a roll call to make sure people can hear and can hear the meeting and we can hear them. So I ask members to introduce themselves. I've been told there are no substitutes today. First one, David Bill.
Good afternoon, Chairman. David Bill here, speaking from Hinkley.
Thank you, David. John Coxon. Obviously not made it. We had a pre-meeting and he was there, but perhaps he's still struggling to get through. Amanda Hack.
Good afternoon, Chair.
Thank you, Amanda.
Sorry, Chairman, John Coxon here.
Oh, well done, John. Thank you very much. I knew you would be there somewhere. Sarah Hill.
I'm here, Chair, thank you.
Thanks. Jonathan Morgan.
I'm here, Chair, thank you.
Joe Orson. Seen him.
Here, Karen, thank you.
Thank you very much. Rosita Page.
I'm here and I can see and hear.
Thank you. And Ted Parton. He was there. Thought he was. He'll turn up. I'd hoped to have the Cabinet Lead Member for Health and Wellbeing and Sport, Lee Brecken, with us, but sadly he had to send me his apologies this morning. He has sent me a few comments, which I might bring into play as and when as we go through the meeting. Minutes of the meeting held on the 9th of September. I propose the minutes of the meeting we held on 9th September are taken as read, confirmed and signed. Is that agreed? Lots of waving.
Agreed.
Thank you very much. Question time. This is from the public. I've not received any questions from the public. Item 3. Questions asked by members under Standing Order 7.3 and 7.5. We have received some questions, 5 questions actually, from Amanda Hack, relating mainly to maternity services. Mrs. Hack has been provided with the answers. You've all had copies of the questions and answers, and they've been published, in fact, on the website. Amanda, I believe you have supplementaries, so off you go.
Thank you, Chair. So question 4 was with regards to follow-up aftercare.
Yeah.
And the case that was raised with me indicates that the 6-week visit, well, it appears in the response, have all been caught up. I'm not sure this is happening in reality. So it's just whether or not we could check back further, please, about how far are we away from the 6-week visits for all new mothers. And the second question, I think, is just referencing on question 5, because I'm not quite sure the question is answered. So my original question was, have there been any changes to diagnosis methods and management of postnatal care? And I don't really think that that's been responded to, because I think this was probably a primary care response rather than secondary. And I was wondering if that could be referred back to the health visiting team, please.
Yeah, thank you very much. So that's fair enough. Is anybody on the line able to answer any of Amanda's, well, particularly the supplementary to question 4 about the 6 weeks? Is anybody online? I don't know, David Williamson?
Yeah. So I think let me just pick up the second question about going back to health visiting, and we'll have a look at that and pick that back up again. I'll need to go back to colleagues to just understand a bit more. In terms of the first question around any of the increases or changes, I'll need to go back and have a look. And actually, that might be a UHL question. I'll just need to just work that through with the health colleagues and come back to you.
Thank you very much indeed, David. That's very good. I'll try as much as I can for the people who are watching this on the YouTube to actually introduce who other people are as we get to their particular points. And that was David Williams, who was been helpful, very, 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 very helpful. That was very helpful. Moving on then to item 4. This is advising of any other items which the chairman's decided to take as urgent, and I haven't decided that because there are no urgent items on this meeting. Item 5, declaration of interest. Do any members have any interest they wish to declare on any topic?
Them starting.
Thank you. Declaration of party whip. Any members have any declarations to announce? And presentation of petitions under Standing Order 35. I've not received any petitions. And we move therefore on to the first substantive item, item 8, which is the Health Watch Leicestershire report regarding patient experience of children and adolescents mental health services, otherwise known as CAMS. And I think we've got for this Mukesh Barrow, and I don't know if you got, is Harsha Katesha coming from as well from Health Watch. But anyway, we've certainly got Mukesh because I can see him on my screen. Over to you, Mukesh.
Thank you very much, Chair. The CAMS reports was something that Health Watch conducted by way of survey to look at the experiences of children and young people using services around mental health. I believe you've all had the paperwork, so I won't go through each and every detail. Needless to say, we had 60% of respondents from Leicester City and 40% from the county. So clearly there's a need to cover a little bit more work around the county areas. We had 87 respondents with 90 completed surveys, mostly online, with some examples of face-to-face interviews. And the predominant age groups were from 12 to 17 years of age. The survey topic was looking at referral processes, treatment, care plans, looking at accessibility of venues, transportation, and also the main focus being on the experience of not just young people using the services, but also their family members or carers. The surveys were carried out at Westcote and Valentine's centres, and generally speaking, halfway through the survey, we were affected by COVID-19 pandemic, so we weren't able to continue as deeply as we would have liked. So the key findings were that waiting times, 57% said waiting times between referral to first appointment was very poor. 63% were not satisfied with the delay between the first appointment and the treatment or the care plan. So it's quite a bit of a delay there. 52% felt that signposting was not ideal to support services whilst waiting the first appointments. 13.5% found signposting information unhelpful and needed improving, and 67% would not know what to do if they were concerned and wanted to raise a complaint. In terms of first appointment and experience, 71% once they got their appointments were positive and they felt they had a positive experience and were listened to. 72.5% knew what was going to happen next in terms of follow-up. In terms of care plans and treatment, 39% said delays added to their mental health conditions. So this would also affect family members in some way or form. And 87% said that care plans, once started, did meet their needs. So that was positive. So by way of recommendations, we found that the focus on reducing long waiting times and keeping people better informed would be a useful adjustment, better signposting, and raising awareness of support services, especially between appointments. Much better profile needed on how patients can make a complaint, and this tends to be a generalisation across the board, whether it's direct or indirect. And further look at low returns from ethnic minorities or marginalised groups, and then better profile of what CAMHS does well to raise awareness of the good practice and also build trust. So that's a summary of the CAMHS survey and report that we conducted. What we would like to do now is to ensure that we get feedback from all of the services and the system leads, including counsellors and committees that we work with, to ensure those recommendations are picked up and followed up on with realistic proposals that align to the current pressures of COVID-19.
Sure. Yeah, thank you, Mukesh. Very helpful. Now, of course, since the last 9 months, the new CAMHS building at Glenfield has now been commissioned and opened. So obviously that might have made a difference to some of the points that you've raised. But obviously we won't know that until the next time anyone obviously makes a similar survey. David, are you able to answer some of those points or respond?
Thank you, and thank you very much for reminding me that if I just do an introduction as well. So David Williams, Director of Strategy and Business Development at Leicestershire Partnership Trust. So we welcome report. It's always incredibly useful to have an external organisation having a look and a review and working out where things are. And I think as you go through the report, while clearly there are issues and things for us to take forward, actually there's also highlighting some really good practice and things to go through. When we go through and look at the conclusion and summary from Healthwatch, I am happy that I'm happy to say that actually we accept the recommendations and accept the information which is in it, and we're happy to continue to work with both Healthwatch, the young people, families, and carers who use our CAMHS service and improve it. Yeah. So absolutely still think it's a challenge, but really up for how we take this forward.
No, that's very helpful. I mean, clearly, I think like a lot of these reports, what we tend to do is obviously let an opportunity for a response, a bit of time, and then either Healthwatch or ourselves will be looking at it again anyway in probably 6 to 9 months. So that'd be useful to do that. Questions? Ted.
Great, thank you. I mean, in terms of the actual the recommendations, they obviously do look quite generic, and the proof, as David has already alluded to, is actually that, you know, what actually are the solutions to put in place for these generic recommendations, and will only the fact that you've already said in this meeting that you accept them was going to be one of my questions, because of course they can make recommendations, but if the trust doesn't actually accept them, then we have an issue. So in between now and the next time we look at this, obviously, you know, there'll be discussions with you to say with Healthwatch and Mukesh whether you agree with them or not. But the one issue I've got is that, and as you well know, you know, obviously I'm a former service user of the mental health services, and the fact that 39% of people, young people, said that their mental health deteriorated in between being referred by the doctor and actually having their first appointment. I mean, what can a young person do when they're feeling that they're already sufficiently ill enough to go to the doctor and say they're struggling with their mental health, and the doctor agrees sufficiently enough to refer them to mental health services in Leicester? You know, what can be done for that group of people, over a third, that actually feel that their health is deteriorating? You know, what can the doctor do apart from medicate? And the other key thing for me is this. I appreciate it's a word that's commonly used, but it's my belief that the word I'm going to use now is overused to the point of where it's lost all authority. And it's this word signpost. You know, we signpost, people are signposted. Because you see, what we've got here is the reason I'm looking down is I'm looking at the figures. The 52% said that signposting was not helpful. Now, adults is one thing, but teenagers, persuading a teenager to do something. So what is it that they were being signposted to? Because whatever it is, either they don't feel it's relevant to them, they don't feel like going on their own, or something's breaking down here. So if the gap between seeing the doctor and having mental health treatment is causing 39% for their mental health to deteriorate, and the solution is to signpost, the evidence would suggest that whatever they're being signposted to is not working, and therefore clearly the only solution is to as much as we can within funding is to speed the time up between referral and being assisted by a a mental health practitioner.
Okay. Do you want me to respond to those?
Yeah, please, David.
And then we'll pick up some others in a minute. It's fine.
Jeanette on as well. Yeah.
Jeanette's there to respond. So I think one of the bits to pick up then is your 2 points. I suppose I've summarised here as saying what can people do in the interim from the point of being referred to the point of meeting a clinician, and then also an update on signposting. So Jeanette, do you want to pick up a response to either or both of those?
Yes, absolutely. Thank you for bringing me in. For those of you who don't know me, I'm Jeanette Burley-Williams, consultant clinical psychologist and clinical director for mental health services within our division, which includes CAMS. And we have provided a response for an action plan for the Health Watch report. We were very grateful for it. And there's lots of points in here which would be really helpful to pick up, I guess, both to show you that not only we're taking this very seriously, but this is none of the issues raised in a helpful way, I guess, were a surprise for us because we have been doing a huge amount of improvement work in CAMS over the last 2 years. You may be aware that we had NHS improvement at our request come to provide some intensive support to look at our improvement plans to make sure they were robust and to provide us with some scrutiny and oversight to that. So I think the report does mention that particularly the issues around waiting times for assessment, we are very confident that they are historical issues. So you'll be aware from the report that there's only 18 of the people surveyed who'd been referred within the last year. So some of those issues are historic. So on that, some of the changes that have been made in terms of access is that our crisis response has been significantly improved. So both in terms of additional investment, so our CAP line, our hub and our crisis and home treatment. So we know that we are meeting targets on that, and we have invested in the front door. So Triage and Navigation is a new service that started, I think it was May this year, to support some of those that initial front door response from CAMS. So we have been meeting our access targets consistently for months now. So those access targets are for crisis referrals. It's a telephone triage within 2 hours, a face-to-face if required within 24 hours. For our urgent assessments, it's face-to-face within 4 weeks, and routine assessment is face-to-face within 13 weeks. So we are very confident that we're meeting those. You're absolutely right that the waits for treatment is a pinch point. It's a pressure point within the service. And again, we have introduced a lot of measures to manage that. Part of our front loading the front door was so that we were very clear what was sitting on the waiting list, which is part of our harm reduction strategy, that rather than have a wait at the front door, it is safer to manage an internal wait because we know who they are. So we have established a waiting list management system and a duty system, which NHSI want us to present on nationally. They were very impressed with that, and felt that we were doing an awful lot of work now to keep children safe whilst they're waiting. It is still a challenge, and obviously COVID has added to that, but we are far more confident in those processes now. So part of that is that children are RAG rated as soon as they come in. Children who are high risk or red RAG rated on our criteria are allocated for acute treatment immediately to manage the risk. So those children don't wait for that treatment, although there may be waits for other treatments, for kind of second line treatments. Within those treatment waits, we have quite a significant proportion of young people who will, on the data, be a treatment wait, but they're actually waiting for neurodevelopmental assessments, a further specialist assessment, which is a big cohort within CAMS and a system-wide pressure in terms of how we manage those children in a speedy way, which again, there's a lot of system-wide improvement work being done. So sorry, just going back, because I'm mindful that I might not be asking your questions, answering your questions. The waiting list management system means that children are now routine. We have what that determines is the minimum level of contact that we should be having with them whilst they're waiting, to review their risk, to review their mental health, so that we can escalate that if need be. And so we have a duty clinician team who are doing that. So that then enables us both to provide information about services that children and young people may find helpful whilst they're waiting. But I do take your point that actually there's not always a huge number of services that we can signpost to, but the types of services we are signposting to are things like COOTH, which is online counselling, general kind of psychoeducation material, so health for kids, health for teens, using some of our digital offers, as well as escalating that to face-to-face if need be. And we've also extended our group work offer very significantly. So we've increased our group work offer so that immediate risk management work can be done within that. Again, that has unfortunately been impacted on COVID, and we have got a recovery trajectory to get that back on track. I missed something? Sorry, I think I might have missed a question.
We've picked up then.
Sorry, David. I say, you've covered it. It's the. It would be useful to know what perhaps, I don't know, Chair, how we who would be responsible for this. If we could, excuse me, have a list of what these sort of non-treatment services are. So when we talk about, because specific always beats generic, when we say signposting to services, it's always good to know, well, what exactly is there? You know, and certainly when COVID eases, will there be physical support groups? When I was poorly, I went to a support group once a month. It was a lifeline. Slightly before the days of the internet, but it would be interesting to see what there is. Don't laugh, Amanda. It would be interesting to see what there is. Seriously, thank you.
Possible?
Oh, I mean, we can set, so in terms of the more generic services that we signpost to, they're on all our clinical letters now and care plans to make sure that people are aware of those. We can certainly give you a list of those, and also in terms of more specific disorder related ones, we have more specific information and services that we would signpost to. So we absolutely can provide that. Our primary mental health team do produce a leaflet very routinely, both for professionals and for parents, carers and young people, of other services that they can access. And we often signpost people to, websites such as Young Minds, and of course our own Health for Teens website, which gives more specific local information.
And chat health is worth raising as well, just online opportunity. So one of the things that we do also provide is chat health, which is where you can just instant message. So most of us, in the nicest way possible, are probably not in the using of instant messaging age bracket. But for many other people, instant messaging is a really good way of communicating, and that comes through to qualified nursing staff in LPT, and support can be provided in that way as well.
Yeah, that's very helpful. Thanks. Amanda.
Thank you, Chair. Just a couple of points on the research and then something maybe more specific to NHS colleagues. In terms of the research, it indicated that there was some that was responded to by the youngsters themselves and some by their parents. And I didn't know whether or not, whilst the parental responses, it looks like it's a much smaller sample size, was there anything learnt by asking the loved one as opposed to the patient? And I didn't know if that was significant enough to get any data out from. And I suppose the difficulty with the information as presented is there was obviously quite a lot of variation between whether they were happy about the length of wait, but we don't know how long they waited for. So obviously somebody being happy about waiting the 13 weeks, the one person that's happy about it because they're aware of it, they know that it's going to come through in 13 weeks. Somebody else might be unhappy about it. So I didn't get a sense of those that were unhappy, how long have they actually waited to get their appointment. I think the more sort of practical question really is particularly this age range 12 to 17. One of the areas that have been totally wiped out in the COVID situation is the pastoral care that's given at school levels, and I wonder what impact that's had on the CAMHS team and the work that can be done with other services that would, particularly those individuals that would see those youngsters on an incredibly regular basis, to keep an eye on them in a professional environment as opposed to maybe a home environment, which might not always be a stable home environment. I was just wondering on your thoughts on that, please.
Yeah.
Does Healthwatch want to respond first?
If I may just make a comment, that one of the things that Healthwatch identified was that we ourselves need to adjust in terms of making our survey format more relevant to children and young people. So, we had defaulted to the traditional, questions, answer in a scale of 1 to 10, or there might be a paragraph. So when we're working with children, and younger teenagers, there needed to be an approach, and certainly it's a learning experience for us, is that the next time we would make it more user-friendly for the target group. And I think that is really important. And certainly that would probably relate to colleagues at LPT who might want to look at signposting information and the design of that information as well.
Yeah, thank you, Mukesh. Yeah, it's helpful.
And I think thinking about how people felt about how long they had to wait, I think this is a difficult challenge in that probably every single one of us would like to be seen today with anything we've got, and there's the reality of managing through. So the bit that we've worked really hard on is about, first of all, making sure that we do triage properly, so that the nature of the request and the need is triaged. And as Jeanette touched on earlier, I mean, urgent callbacks can be within 2 hours, and face-to-face can be within 24. So there's a response of where things are going. Clearly, the challenge that we all have is that at the point that we contact somebody, we believe that we have an urgent need. And it's about just how we explain that and talk that back with families and carers about the level of need and how we support it through. So we do track our wait times and we continue to work them through. And Jeanette just touched on earlier that actually we've redeveloped our processes to a point where we would work to do a triage and assessment very quickly, in order that then we've understood everybody, and if you want, they're in our fold waiting for a treatment program where we can more closely monitor them than if we didn't know anything about them. And that's about maintaining and protecting people. So I think we try and manage that and look at it and working through where we go on there. In terms of your pastoral point, I think that's really important, and the NHS doesn't work alone in terms of looking after children's mental health and well-being, and there's a really, really important bit for schools. One of the things that we've been lucky to be supported with across the city, the county and Rutland is mental health supports in schools. And so we're building and increasing that over time. And so LPT are working with the local schools to increase the amount of support, training up professionals within schools then to be able to support, as well as be able to link in with LPT staff and others to support and develop it through. So that pastoral care bit, I think, is really important. We've plugged and pushed Healthy Teens just a couple of times today, and as a website for providing advice for 12 to 17-year-olds, that's a really good place for other people to get support and pick things up. So I think there's a range of different things, but absolutely we're committed to doing this in partnership to kind of take it forward.
Yeah, no, thank you very much, David. A point really perhaps to Mukesh. I mean, it's general, this is, it's not necessarily about this report, but just generally. I mean, how are you finding, obviously now with the pandemic and everything, are you feeling maybe that some of these surveys you put on hold until it's back normal again?
I mean, that's a very good question, Chair. The first thing that we acknowledge is the pressure points on the system, and especially staff. And we when we have an overview of health and social care, that includes staff as well as service users and communities. So we absolutely acknowledge that. And as David highlighted earlier on, it is about working together. Yeah. And for us, it's a question of how do we adapt our statutory remit to keep an eye on patient needs and experiences, but to do it in a way that acknowledges the stresses and the pressures. And the major changes, with Absolutely. Regards systems, training processes. How do we do that? I think there's something in issues like training for receptionists, GPs, and dentists, around non-medical or clinical areas, so customer care, patient experience. Those are the key changes that we could focus on. And also, one of the points when David was responding to the question about pastoral care is that we could also look at local authority youth workers and neighbourhood centres, community centres where there are children and young people's youth clubs. And yes, they might be shut down at the moment, but they might have websites and web pages. Yeah. So that's another way of reaching young people and getting their experiences and views as well.
Thanks very much, Mukesh. I just felt it was worth airing just to see where you were coming from on that, because it's obviously important. No more questions. No, I've got no more questions for you. So thank you very much indeed, Mukesh, and obviously David and Jeanette. That's very helpful. So we'll move on to the next item, another Health Watch report. And this time it's the title is Using Dental Services with Special Educational Needs and Disabilities. So SEND patients. Mukesh, do you want to take us through that then, please?
Thank you, Chair. So this was conducted around August, so it's fairly recent, and we wanted to understand the experiences of those using dental services, especially those with special education needs or disability. There will be some similarities, which I'll cover later on. The coverage, again, we have our Leicester and Leicestershire focus. Health Watch, in terms of our contract, covers both areas. And almost most of the respondents to the survey were city-based. So we acknowledge that that needs to be looked at in terms of the coverage of the sample survey. Relatively speaking, it was a smaller survey with 25 people responding online, 4 of which were face-to-face interviews. We used a QR code, which we found that was quite useful in getting people to respond very quickly to survey questions, and certainly that was used effectively and commented on when we attended the local offer events organised across Leicester and Leicestershire. and also we organised a hidden disability event as well. So the technology is beginning to be used, and in some cases it excludes people with digital exclusion, and in some cases it also is a benefit as well. So that's an area that we want to explore further. Key findings of the reports were that more than a quarter found that finding and accessing services was quite poor. So there's a better need for information and awareness, and maybe targeting that profile raising to specific groups. And again, there might be disability or ethnicity or any other areas where information may not be reaching those target populations. And certainly the data analysis will be able to reveal where there are gaps in those areas. Publicity on SEND dental strategies. Again, there was a poor awareness of the difference between general dentists and specialist dentists who work with SEND patients. So a need for proactive awareness raising of what services are out there. And then information accessibility was good, but again, the profile was poor. So once people received the information, they found it was clear, accessible, easy to digest, but it was trying to get hold of that information in the first place. So we get down to the experience of patients and family members. So generally speaking, customer service was rated as very good, and in some cases it was patient-centered. In some cases, the dentist would talk to the parent or the carer as opposed to the young person, and also some young people were not prepared, especially if they got a special education need or disability, on what the dentist would look like with their PPE equipment. So, that could have been quite traumatic or frightening. So the question, would be, how do we perhaps have some easy read or visual images that can be sent in advance so that parents or carers can, get children, young people more familiar with their experience at the surgery. The environment, the smell of the chemicals used, what the dentist will be dressed like. So again, is that customer care from a patient or a young person or children's perspective rather than this is a dental service. 43% felt they had a poor experience of registering with a dentist or attending appointments. That again needs to be looked at in terms of the COVID-19 restrictions kicking into place and not being able to get dental appointments, and whether information was readily available about, okay, if you can't get a local appointment, where do you go next? And that might be a question for the local dental committee. 40% stated that their involvement in their own care was poor. So this dialogue between the practitioner and the clients. 39% experience of finding and accessing dental services for SEND patients was poor. That again repeats that question about specialist services and whether people know where to go for those. We acknowledged that we needed to look at the design and the length of our services, surveys, and how we improve that. Again, in terms of disability, using images or easy read, or indeed even having workshops online with specialist disability support organisations. And then some dentists asked quite a viable question, that how would they know that the patient has a disability or a learning disability? So unless that was advocated to them in advance, through some form of referral or documentation or patient record, they would not know how to make a reasonable adjustment. So coming on to recommendations, some guidance, perhaps some e-learning for dental teams, including not just the dentist, but the reception staff as well, on how to support families or people coming in with appointments, to have a better awareness of SEND issues, and how to ensure that customer service was adapted in terms of that reasonable adjustments that I mentioned earlier on. Perhaps there might be a video or flyers that show PPE equipment that can be distributed to families and support organisations. That could be a MP4 format, so it could be emailed. The costs are reduced, but it highlights. It could be a YouTube video, and it just highlights what your experience, what you will expect when you go to see a dentist and you have a SEND, health condition, and better profile of SEND specialist services. Perhaps some better links between GPs and dental services, enabling proactive reach out, between dental services in advance of the appointment, so that that communication and contact could be made with specific families or support groups. And then most respondents did not reflect the diverse makeup of Leicester and Leicestershire. So again, perhaps looking at some of that data. And then we looked at the need to better promote that NHS 111 can be used for those people with dental emergencies. So people were not aware that if there is a dental emergency where there might be a infection or something like that, that they can ring 111. So finally speaking, the survey was shared online through the Special Education Needs and Disability Information Advice and Support Service, SENDIAS, through our own social media, also with key NHS and social care partners, local authorities, UHL, LPT, clinical commissioning groups, and information sent out through various networks. So that's a general overview of the dental research.
Yeah, thank you very much, Professor. I don't think we've got anyone online from the dental community. I wouldn't expect them to be here anyway. But we are having a report on this at our joint meeting, which is with the City and Rutland, on generic dentistry and availability of dentistry. So that will be coming up in December. Anyone got any particular points they'd like to ask the question? The only other one I've got is it occurs, obviously. You obviously did this in August, and obviously it's quite a small sample, but nevertheless some really important stuff there, very good recommendations, and hopefully we can follow up with them and go through. I mean, it's not just SEND people who might be terrified of dentists. I'm one. Hated them ever since I first went to one. And just never have liked them. But no, I think it's really good. Thank you very much, Mukesh. Anyone else got any questions? No. But we'll obviously keep following up on that. So that's very helpful. Thanks.
Kevin,
yep.
Kevin, just a quick one. It's in relation to cost. Because have you got anything, because we've debated this earlier, because the cost sometimes even under National Health Service is very high, but do I assume that SEND people don't have to pay? Just talk me around costs before you go. Good stuff.
Thank you. Interesting question. To be perfectly honest, I don't know about the costing mechanisms, but I do know that over and beyond SEND dentistry, that we are hearing from some people that due to lockdown, that they can't get dentist appointments or GP appointments. However, some people are being told that you can't get an appointment, but if you wish to go private, you will get an appointment overnight. And that is worrying, because that almost bears onto the that sort of commercialism aspect. So that's one we're watching out for. Yeah,
thanks, Mukesh. No, that doesn't surprise me. It's certainly the message I'm getting from people in my village here. If you can't get an appointment, NHS appointment, you ring the same surgery and say, "I'll go private," and next day. Yeah, quite. Okay, thank you very much, Mukesh. Moving on then to item 10. This is the health performance report, and I can see Andy Brown eagerly waiting there for to get going. And I think you've got Kate Allardyce from the Commissioning Support Unit and Hannah Hutchinson, who I understand is having to work from home. But aren't we all? But we may get some interruptions from young people. But thanks very much for letting us know. So Andy, over to you.
Yeah, thank you. I'll just say a few words in introduction to the paper. So the report before you is an update on CCG and health performance, particularly public health performance, and based on the data that we had available in October. So the sort of latest available data. You recall last time we came to you in June, where we were just sort of starting to come through this first wave of COVID. We didn't have certain data available to us at that point because of the way the health system was operating. But we did hope by this time that we'll be in a different place, both in terms of COVID and health reporting and what we were looking at. But unfortunately, we are in a similar position still in terms of the lack of availability of certain data because of the focus of providers on COVID, understandably. So the format of the report is fairly similar to the report in June. So we're looking at some recent data that's been produced on COVID-19 locally, which is now a critical part of our sort of performance monitoring and reporting. So we have included the supporting reports that are done on a weekly basis by the analysts now to help the public health team and colleagues with COVID monitoring. Now, I do understand you're having a presentation later on in the agenda from Mike Sands on the latest information on COVID. So we weren't particularly proposing to go through that section here, but when it was written, I wasn't aware that you got a separate presentation. So to save you a little bit of time, we won't go through the detail on that part, but certainly we can take any questions on that. Then we've got a separate section on CCG performance, and as you say, Kate and Hannah Hutchinson in her new role will be saying something about that, and also the new structures that are forming in the CCG to take forward sort of the performance focus there. Information on quality and never events. And then in terms of the public health section, we have included some extra information this time around on both benchmarking and the progress of public health data against last year, some of which will go into the council's annual report, which will get to council in December. So I thought you'd be interested in just seeing that in advance and potentially asking Mike and the analyst 1 or 2 questions around that if needs be pre the council meeting. So we have also included some of the narrative that supports that data, so some of the work that goes on in the service, which we don't always sort of bring that to you, but I thought you'd be very interested in that this year, given all the extra work that's gone on and some really good work that supports those outcomes. And then finally, the Better Care Funds, the 4 metrics in the report we sort of include at the end of the report. So just in terms of ESF handover, perhaps if I just do the Better Care Fund metrics first. I know that's at the end of the report, but just to sort of save us handing over a couple of times. These are in paragraphs 29 to 32. So the 4 metrics, in terms of permanent admissions to nursing and residential care homes for older people, you'll see that there's been quite a drop in the forecast numbers of permanent admissions, 373 per 100,000 forecast against 552. So quite a noticeable drop in sort of permanent arrangements, and perhaps understandable given the sort of COVID situation that people have been looking at alternatives to permanent care, with possible knock-on effects there. And also similarly, the non-elective admissions to hospitals has been shown quite a reduction from the normal operating period. So I think there's 17,118 in the recent data compared with 23,000 the year before. So again, quite an impact on people turning up at hospitals within that period. The DTOC data, we haven't got any latest data on delayed transfers of care, unfortunately, so we're not able to sort of provide any information around that. But reablement, we are still monitoring that. People at home 91 days after discharge from a hospital, and that area seems to be going well still, just under the target of 88% at the moment, 87.7. So it looks like reablement services are sort of coping with the numbers around that. And so that's all I wanted to say by way of introduction in the BCF, though I know Hannah and Kate want to take you through quite a bit more detail on the middle section of the report. So I'll hand over to Kate initially.
Yeah.
Hello there, hi. I'm actually going to hand straight over to Hannah, actually, just to introduce herself. Hannah's the new Assistant Director of Performance Improvement for the 3 CCGs. So Hannah, if you wanted to just mention a few things, didn't you?
Yeah, thank you very much for that. So thank you for letting me be part of this meeting. I just thought it would be helpful to introduce myself and also talk a little bit about some of the changes that we've got at CCG level and the work that we're trying to do to improve performance across the system and health and social care outcomes for our population. So one of the main ways that we're looking into doing that at the moment is actually through writing a draft quality and performance improvement strategy. And that's around delivering high quality health and social care to support the population of Leicester, Leicestershire and Rutland. And it's around starting to combine quality and performance improvement to drive and deliver assurances for us all. So we're trying to move away from really rigorous performance monitoring to much more a culture where we're clinically led and we collaborate and we share across providers to improve outcomes for our patients. So it's a bit of a cultural shift really in how performance improvement is going to work and how it's going to look. And one of the ways that we're doing that is actually through a united system of leadership. So we have come up with 9 design groups within the 3 CCGs, which are all clinically led and managerially supported with independent assurance around them. And the design groups are ways of offering quality and performance improvement, and they work across all providers and all 3 of the CCGs. So you'll see those within the report. So they're on page 76 at the end of paragraph 14. So while we're absolutely still working to the NHS England oversight framework and the standards that they require from us, we are trying to look more at how we can work collectively to commission system goals. So by coming up with a joint strategy and a joint performance improvement framework, that's one of the ways that we're hoping we're going to see some of these changes, so we can really start to collectively take responsibilities for areas that are challenged or where we're struggling. I work really closely with Kate and her team, and I've also got a very small team to try and support these design groups to start having conversations around what does good look like, what does quality mean to our patients, how can we try and improve outcomes for patients, because we can move the metrics hopefully from red to green on a dashboard, but actually are we delivering something better for the patient? Is it of a higher quality? And so that's the piece of work that I'm starting to do, and with Kate and her team's support, hopefully you'll see some of that information starting to filter into these papers. So I'll hand back over to Kate now, and she can talk you through the actual content of the paper. Thank you.
Thanks, Hannah.
Thank you. So yeah, moving on to section 17 and 18 of the paper. As you'll be aware, we've been presenting the CCG assurance framework to the committee for well over a year now, and that's made up of a set of around 60 metrics which NHS England use to monitor CCG performance. So the actual assurance framework hasn't yet been updated for this financial year, and the national dashboard that we generally use as our main data source hasn't been updated since February. So I've decided not to include that within the appendix of this report because it hasn't actually changed since the June position that you'll have seen. Obviously, you can be assured that we do report monthly to CCG quality and performance subgroup on any available data, whether that's national or local data in relation to those 60 metrics. And within section 18 of the paper, we've given you an outline of some of those key metrics, which again isn't too dissimilar from what you've seen previously. So I'll just take you through a few of those. So in terms of cancer, referral numbers have actually gone back up to pre-COVID levels, which is good news. Although the number of patients that have breached has actually increased slightly in September, but patients are, clinically prioritised through the national guidance that's been set, and I'm sure you'll be aware that the independent sector is also being used where appropriate as well. So looking at the 4-hour A&E target, we are expecting that this metric will change next financial year. Some trusts, not in our local area, are looking at sort of doing some work around those new metrics, but that hasn't been rolled out nationally yet. There has been some improvements in performance around the 4-hour wait in October, and early signs that for November are looking positive as well. And that's despite an increase in the attendances at A&E. So again, some positive news there. Looking at waiting lists for planned care. So again, we've got September's figures, and although there has been an overall increase in the waiting list, we have seen the percentage of patients that are treated within 18 weeks actually increase. So that's some good news. Moving on to mental health, the IAPT, we unfortunately have only got performance up to July, but that performance level is very similar to what we were seeing this time last year. And services for IAPT have moved kind of online and telephone appointments. We are achieving the national target in terms of patients' recovery. So again, that's good. Dementia, so this has been quite a challenge really, and this isn't just for the Leicestershire area, this is seen across the country. The metric here relates to patients being registered through primary care as having dementia, and there's been quite a reduction in terms of the numbers of patients that we've seen, and that's primarily because patients and carers are staying at home. This is a particular cohort of patients that aren't, or that could be reluctant to attend face-to-face practice appointments. So section 19 of the report outlines the cancer performance. We have had an update since writing the report. So some positive news for September is that both of the 2-week wait metrics were achieved. We've just had that information out this week. There is a new cancer metric as well, which is around faster diagnosis. So that's 28 days for a diagnosis, and that target has been achieved across all 3 CCGs as well. Section 20 just very briefly outlines one never event that happened at UHL, and certainly more information is available in the public domain on their board report. And obviously, importantly, there's some mitigating actions that have been recognised from that never event. Then final couple of sections, section 21, some areas of improvement. I've already mentioned around the increase in percentage of patients being seen within 18 weeks and the cancer targets. And as Hannah's outlined, we're going to see some quite big changes in terms of performance reporting for CCG. So when that gets organised and we're in a good position with it, then obviously that will be reflected in any future reports that we bring here. Okay, so I think I'm now, unless there's questions now, or hand over to public health colleagues.
There are a couple of questions.
Okay.
Which I presume are for all the bits we've just seen. Amanda, I think you're first.
Thank you, Chair. It was just a really quick question. It'll be no surprise on the 62-day wait, because I ask about this fairly regularly. I read a newspaper article yesterday, obviously really great source. Now, to be fair, it was the MP that's suffering with breast cancer and the former MP that's suffering with breast cancer. It was a really good piece. But what was said in that article was about the amount of particularly breast cancer diagnosed patients where they're on maintenance treatment before surgery can take place. And I didn't know whether or not this was being calculated as official treatment rather than treatment before surgery or something. I didn't know whether or not there was any detail that sat behind those numbers.
I don't know the technicalities behind that, but I will find out. I might need to drop you an email separately so I can understand it a little bit more, if that's okay.
Of course. No, that's great. Thanks, Kate.
All right. Thank you.
Okay, thanks very much. Rosita.
I Hang on. Thank you, Kevin. Thank you. I've got a couple of questions. And if I can, hang on, let me go back. On page 76, it is moving into delivery. And there is that design group statement. Have we looked at, if we're looking at delivery, but how do you access that model? And so that is a simple question on how is the model accessed. On page 79, there are the cancer metrics. And if we are talking a cultural shift, so how do we still monitor? Because at the end of the day, some of these targets haven't been met. And, you know, that to me is quite worrying if we're, you know, so how are we combining the metrics with the new model? On page 80, hang on, the question under 23, it says.
Hold on, we haven't got that yet. We've public health, we haven't touched that yet. That's good. Yep. About to happen next.
On page 80,
yep.
Hang on.
Public
on
health.
Page 80, it states under 23, the county is placed as the third lowest.
Yeah, that's public health.
Yes, public health. Could you explain? I can't hear you very well.
It's public health. And
yes.
Natalie will be talking about public health in a minute.
Okay, so I'll ask that question then.
Yep.
Hang on, one more on the statistics. Page 102, and I can't remember what my question. Oh yes, on page 102, we are talking Harborough, and I will repeat that later, as the lowest rate of COVID. Please bear with me. Melton Borough is smaller and has got a higher number. Harborough's COVID numbers are relatively low. Now, I keep getting constant reports of COVID cases, and I was thinking about it, and it doesn't, you know, it just doesn't correlate.
You're talking,
so I've come.
Rosita, you're talking public health again.
But it's also statistics.
It is statistics, but it's
yes.
not. It's
so just hear me out. Just hear me out. So the question right. really to the statisticians is, if you have COVID, I assume it is then translated to the address of the patient, and that is recorded, the numbers, by the address. I have got Europe's largest logistic park in Lutterworth, and the patients are coming from all over, and the rate of COVID is quite high due to car sharing and whatever, but it doesn't show up in the statistics. Is there any other way that it can be recorded? Because it's giving the false impression, and that is to the statistics. And I think that's me done on my questioning. Thank you.
Well, we'll let Natalie do her bit in a minute. Kate or Hannah, are you able to answer the first two questions?
Yeah, that's fine. Certainly in terms of the mental health metrics that are on page 79, we will continue to report on those no matter how we end up changing our performance report. You know, these are national key cancer metrics, amongst others as well, but there's no chance that these will disappear unless there's some change in government direction in terms of we can stop reporting, but I can't see that happening. These metrics have been around for a number of years now, so yeah, they'll be staying for as long as we need to.
Yeah, thanks, Kate.
Right. Can you just go to page 93 at the bottom? It says death counts are based on death occurrences. Now, could you explain that statement under little one?
Okay. Oh, you're looking at public health again.
Oh.
Shall I hand over to Natalie and
I think it might be easier now because But we have still got questions from Ted Parton to come.
Oh.
Ted, yours about non-public health, I dare say that.
So I believe that my question is not, it will fit the criteria. It's a question for Hannah about something she said.
So, Natalie, yes, you might as well do your bit. Thanks very much.
Would you like me to answer those questions first, or
yes?
go through the data?
I mean, you may well find it fits in as you do your bit anyway.
Okay. I think I'll go for the questions first, if that's okay. So just in terms of how we record the address for the COVID data, there is two ways that we can look at this. So firstly, we can look at based on the address which the person has registered at their GP practice. And that is how we are held to account, and all the data that is currently published is split. But we are also starting to receive the address of the person when they took the test. So, for example, if I was a student, I hadn't changed my GP practice and I was still registered living with mum and dad, but in fact, I went to university at Newcastle and that is where I took the test, we would also get that information to say, yes, they're registered in Leicester, but actually they took the test in Newcastle. So we're starting to get an understanding of how many people we are kind of held to account and registered with COVID, and how many people actually in our area have COVID, and they are two slightly different things.
They are, yes. I mean, I've been picking that up for a while now. As you say, it's where the cases are, not where they're registered.
So the figures which we see, say for instance, of the Harbour district, do they have taken account of all of the people, for instance, who work at Magna Park and have COVID, because are they added to those figures?
So it really depends on where they are registered for their GP practice. So what address they have told their GP. If it is in Harborough, then they will be accounted in the Harborough's figures. What we can then look at locally, obviously, is where they took the test, and if that was in Harborough, they would come up in those figures, but that is not the published data. And I think, I'm sorry, I just saw that Mike wants to come in as well.
Sorry, yeah, I can't get back.
Yes,
I suppose
the
obvious comment, though, is that if you work in Harborough and you live outside of Harborough, your cases will be assigned to where you live, not where you work. So Harborough won't be knackered by having Magna Parking. Yeah.
Yes, because that is the issue. The cases are reported are really, really high. And my parish councils keep coming back to me saying, you know, we know of far more cases than 4 which are recorded. And so I just wanted to confirm, because that is what I've been told, telling them that the cases, you know, of all of these workers will up to Sharnwood or Hinckley or whatever. Yeah. Okay. Right, that's that answered. Can I just come back to page 76? I've asked whether we have got, and you said you're monitoring it, but I was also asking, we are talking about a delivery model here. What is the access into that delivery model? Yeah, that is what I can't get my head around. Could you explain that to me, please?
That'll be Kate. You're on a different person. You're jumping about a lot.
Yes, I know. I'm sorry, because I had
a phone call. To respond to that one.
Please, Kate.
So it might be helpful. So I think if there's information that you'd like around those 9 design groups, you can absolutely contact me directly. All of them are meetings that are clinically led and have different providers, local authority, hospital, a range of different people, including patient representation. So they all meet pretty much on a monthly basis, but if there's a particular area that you've got interest in, it might be worth making contact outside of the meeting and I can have that conversation. Does that answer the question?
Yes, what I was asking, in a way, we're seeing a delivery model with design groups, but what you are saying, there is access and that is considered in a different model. So we're not looking at this in isolation, yes?
Absolutely not. And all the information from those design groups is reported into a central place, so we can see from a performance, quality, activity, finance perspective how they're doing.
I just wanted confirming that it isn't a standalone, that it is, you know, a whole puzzle where all the pieces fit together. Thank you. Right. And Kevin, can I ask the public health questions, or do I have to wait?
I think you've asked them, haven't you?
No, the public health question was in relation to this
paragraph 23. Paragraph 23.
Paragraph 23, the spend. So it says that it's placed as the lowest. Is that because of funding, or is that the funding is received but we are not spending, or the money goes on something else? And then on page 93, the little, you know, the recording issue. Yeah. Okay, over to you.
I think on the spend level, this is taken from the SIPFA return, so it is the local authority's actual spend on public health. But I think it very much closely relates to the grant as well. I think we are one of the lowest granted authorities as well, though I think the County Council may put in some of its own resources into that. But I'm sure Mike could sort of make a comment on that as well.
Yeah, historically, it's always been the case. When we transferred over back in 2013, the public health grant was set on historic levels within the NHS before we transferred over. So I think Leicestershire was the 8th lowest council of the 9 upper tier local authorities in the East Midlands per head of population, only above Rutland. So, you know, NHS Leicestershire County Rutland was never a big spender on public health. That was then reflected in the grant formula. So obviously we've had cuts over the years. We've had a bit of uplift in a couple of years, but they've never sought to really close the difference between top and bottom. So yeah, like a number of other issues with local authority financing for Leicestershire, we're down the bottom of the table.
Yeah, it's Mike.
Thank you. And on page, I'm done after this one. Page 93, right at the bottom, the death counts are based on death occurrences. Just explain that to a simple layman, because obviously that affects the figures. And
I'm going to leave that one for Natalie, because I would imagine deaths really would be based on death occurrences, because if they're not, I don't know what they are. But
but it says death is counted involving COVID mentioned, but please note may not have been confirmed by the test, because then it, you know.
Sure. So there is another way to record death. So we look at the date of death, but we also look at the date of registration. So when the death was registered to a registrar. So we are using the date of death at the moment because we're seeing a greater time lag between date of death and date of registration because of COVID. Does that help? Does that answer it all?
So what you're actually saying that sometimes what is on the certificate, so there's COVID on the certificate and it may not actually be COVID.
Okay, so the other thing is that the data that is presented there is from the Office of National Statistics, and it doesn't have to have a positive COVID test. It all depends on if the certifying clinician thinks that COVID is present or there is a positive test. So it could be either an overestimate or an underestimate either way.
Right, and that is what I was trying to get at. So it is actually, we're not sure for certain. It could be over or underestimated.
Yes.
Thank you. Thank you.
Thanks. Ted, do you want to ask your question now?
Please, yeah, thank you. Firstly, Hannah, when you started your presentation, you spoke about what your role was going to do and how it was going to be patient outcome led. So could you please explain again what your role is, and if what you're looking to do now, when you were explaining along with Kate about how you're looking to change the metrics. Well, what happened before? What was the previous role that perhaps wasn't seen to be so patient-centred. I'm trying to understand what it is we're changing, what we had before, what we're doing now, and what we hope to achieve, past, present, and future.
Thank you. So I think in the past we have focused a lot on the numbers. I think from a reporting function that we focused a lot on how our individual providers or individual pathways are performing against a benchmark standard. And what we're trying to do now is not move away from the fact that we still need to collect some of those metrics, but start to move towards much more of a population health management approach, where we look at more collective outcomes for the patient. So what would enhance your experience of care, and what do we need to measure in order to show that we are improving that? What would improve health and well-being of your population? What can we do to address health and care inequalities? And I think certainly in health, we have had this number of metrics that we've reported on, and I think that some of the gathering of intelligence into one place around serious incidents and complaints and some of these wider outcome statements haven't necessarily all been triangulated together to give the wider picture of the service that we're offering to the patient. So how can we increase the well-being and engagement of our workforce? And if we're successful in doing that, what impact will that have on the patient? If we've got a service going into the home, how can we make sure that they aren't just going for one area of work, but we're really working across disciplines to look at that patient much more holistically? And I think that's the nuance in change. It's more of a cultural shift, I think, in what we're doing and how we're looking at those measurements.
And how would the staff that are on the ground feel about that? I mean, are they aware that is that a change in job description, or is that bringing other staff in as a result of what they're seeing?
Yeah, so we've had a big management of change process going on within the 3 CCGs. So we're working very much more collectively together across Leicester, Leicestershire and Rutland. I think we're also trying to work much more closely with providers in Leicester, Leicestershire and Rutland as well. So it's early stages, but for example, we're looking to come up with an outcomes framework in terms of what we can improve, but with sign up from different partners. So that would be Leicestershire County Council and Leicester City Council and the primary care networks and the big hospital providers and community providers as well as making sure that we've got patients who are signed up to that. So I would say it's early stages. So in terms of all stuff on the ground, are they aware it's taking place? I think it's sort of filtering through slowly but surely. Just to make sure that we aren't looking at disease-specific interventions in isolation, but how we can work, I suppose, again, over a longer period of time. You know, if we want to prevent ill health, how is it we can do that rather than necessarily working on metrics within a financial year in the health service?
Yes, thanks.
Okay, and well, I'm just curious, what's the link with your job description? Seems to mention Lancashire.
No, that's Kate.
I do apologise, Kate. Sorry.
No, that's all right. That's all right. So the commissioning support unit covers obviously Leicestershire, but it goes right up to Lancashire as well. So that's just the name of our NHS organisation.
Okay. Yeah. And the final question is, with the COVID numbers that Rosita was talking about with Natalie, have they been adjusted to bear in mind the change that was made in the summer when there was statistics from PHE, NHS England and the ONS, and an adjustment was made in the mortality figures in the UK? Has that figure of 89 been adjusted as a result of the changes that were made?
Sorry, so these figures have been reported on a weekly basis from ONS, and they are updated retrospectively. So so any changes that have occurred in the previous weeks will have been updated.
Okay. So, but do we know whether the numbers were adjusted up or down?
Well, if you're referring to the changes in deaths when they were reduced because it went to less than 28 days, the deaths within 28 days of a positive test, as opposed to deaths occurring at any stage after a test, that wouldn't affect the case data that Natalie's reporting. But the case data, as Nat knows, I mean, it does go up because some data is reported on the day that the result comes back, but actually sort of the later arriving tests are added in after the event. So essentially what is reported in Natalie's report is the view of how many tests and cases there's been.
Yeah.
Thank you very much, everybody.
Thanks, Ted. Natalie, do you want to actually do the public health section of this performance report?
Yeah, okay.
We're doing this back to front then, aren't we? You ask questions first and then do the report.
One of our members took us off course. Yeah, not to worry.
So I was going to leave the COVID reporting to Mike. So I just wanted to draw your attention to Appendix 3 and 4, which gives a summary of all the other public health indicators. It's just worth noting that these indicators only go up to either 2018 or 2019, so they will not be affected by COVID currently. And that's purely because of the data lag that exists due to national reporting of figures. So just to draw your attention to a few indicators. In terms of life expectancy at birth, Leicestershire has continued to see an increase in these figures for both males and females, and we continue to perform significantly higher than the national rate. We've also seen an improvement in the inequality in life expectancy figures. So that examines the difference in years of life expectancy across the social gradients. So what is the difference in years between those living in the most deprived areas and those living in the least deprived areas? And as I said, we've seen improvements, and this is currently declining in the county. So the latest figures for males stand at 6.3 years, and for females it's 5 years. So just to give a bit of a national comparison there, it's 9.5 years for men and 7.5 years for women as well. What we have seen, though, is a decline in the healthy life expectancy for both genders in the county. So we did previously perform significantly better in this area, but we're now only performing similar to the national average. And we've seen a drop in both males and females, but just for the last year's worth of data. So we'll just monitor that to see if it is a blip or if we're going to start to see a declining trend. We have seen some good improvements in our smoking prevalence, so that has decreased compared to last year, and also improvements in completion of drug treatments programs as well, along with improvements of the percentage of people being physically active as well. Just to draw your attention to some areas of concern. So we are seeing an increase in the percentage of adults that are overweight or obese in the county. So for the first time, we are now performing significantly higher than the national average. So nationally, it stands at 62% of all people are overweight or obese, and in Leicestershire, it's 64.5%. And we've also been seeing a decline in our chlamydia diagnosis rates for our 15 to 24-year-olds. So currently, over the past 3 years, we've seen a decline in these diagnoses, whereas nationally, we are starting to see a gradual increase. So again, this is something that we are monitoring quite closely. But I'll stop there and happy to take any specific questions.
Thanks, Ashley. Very good. Interesting. Any specific questions then on now we've got to public health? Well, it's particularly the tables at the back. I was going to say red. I was going to say red, amber, green, but it's yellow. Yeah. Got any questions? No, there's nobody. Gosh, muted everybody. Oh, I see. I now know why, Rosita. Thank you very much. Right. Okay. I think Andrew and Kate, Hannah and Natalie, I think you're off the hook. Thank you very much indeed.
Okay, thank you, Chair.
Thank you. Thank
And
you.
I finally got the answer to that question I've always wanted to ask about Lancashire as well. I remember when it was Greater East Midlands, but got confused when it went to Lancashire. That's lovely. Thanks very much. Item 11 then, bit more public health here, and it refers in a way to what Natalie's just been talking about actually. This is development of a health weight strategy for Leicestershire. Our lead member for health and wellbeing, Lee Brecken, was very much part of getting this going, and this is part of the consultation really, I think, isn't it, Mike? You and Elizabeth. Yep.
Yep, so a very brief introduction from me. Thank you, Chair. So as paragraph 1 says, the purpose of this report is to seek the views of the Scrutiny Committee on our proposed healthy weight strategy that went to Cabinet prior to going out to consultation. It comes to Scrutiny today as part of that consultation process. Unfortunately, under government regulations, I am, as DPH, unable to talk about anything other than COVID at the moment.
Oh,
so I am going to hand over to Liz Orton, who's hopefully on the line, consultant in public health, and it is, I mean, it's Liz's work, so it's entirely appropriate that she takes the credit for it and presents. So, Liz, I'll just hand over to you.
Okay, thanks, Mike. So as Mike said, today this is very much about bringing this strategy, the draft strategy, to the committee for feedback and reflection on our approach and comments and direction to take forward. The work has been, the draft strategy, development of the draft strategy was preceded by the Joint Strategic Needs Assessment chapter on obesity, physical activity, healthy weight and nutrition, which was published last September. And as Natalie's just pointed out, that highlights that two-thirds of people nearly two-thirds of people in Leicestershire are overweight or obese, and also two-thirds of children by year 6 are overweight or obese. So it is a significant problem for us, and you'll also be aware that there is now a connection between adverse COVID-19 outcomes and obesity as well. So it is a significant concern, particularly as well at the moment for that reason. At the meeting of Cabinet in October, they approved the draft strategy to go out for consultation, and I've summarised in paragraphs 8 to 11 our approach that we plan to take, and that's what I'd like your feedback on today. So briefly, I won't go into it in loads of detail, but briefly, there are 3 key areas of focus, 3 key themes for the strategy. Obesity is a complex problem. There isn't one reason why people are obese. There's lots and lots of reasons about our environment and about access to food and about our relationship with food, and which is why we've broken the approach into these 3 key areas. So the first area is to look at our healthy weight environment. And we know that the environment is really key in influencing our decisions about our weight, and also physical activity and how much physical activity opportunity we have. So the first part of the strategy is to work with partners across the whole kind of system of sectors to look at how we make available to people healthy and nutritious food in lots of different settings. That would include settings like schools, in workplaces, in hospitals. It really is working across different partners. The second approach in the strategy is to support those people who've identified themselves as being overweight or obese and wanting to seek support to help them achieve a healthy weight. So that would be the weight management services that we have in the council, and trying to encourage people to take up those opportunities, but also working with the health service in the very specialist services that they have for obesity and weight management, the bariatric services, and also just generally kind of supporting people to manage weight themselves, so they don't have to come to our services. We can signpost them, we heard that earlier, we can signpost people to, you know, self-management approaches, whether that be commercial providers or NHS website, which also has self-help resources. And then the third key area that we'll be working in is around our role in leadership. So that will be looking at our policies to make sure that we have policies that are conducive to healthy weight, and also and looking at how we train our workforce, the frontline staff in all of our different services who have those conversations with people about their weight. Do those members of staff, do those professionals feel confident to be able to have conversations about obesity, particularly if they are overweight or obese themselves? How do we train them to have those conversations with people? So those are the three kind of broad approaches that we're taking to this strategy. For the consultation, just to provide you a bit of information about that, there's an online survey, which is our usual council approach, where we've asked some key questions of the public about the draft approach that we're taking. But in addition to that, because we've done a equality and human rights impact assessment, we're doing that throughout this process, but we've started to do that and identified some groups who might need more support in this area. So people with learning disabilities, people of certain Black and minority ethnic origins might also need further support, people of different faith groups. Those groups we've identified as needing a little bit more specific targeted consultation, and so we're doing that separately in addition to the online survey. We also are working directly to engage with CCGs, with our chief officers in the leisure services across the districts, with the Health and Wellbeing Board, and we'll be going directly to them to present the strategy and seek feedback, much like we are today. And we have an easy read version as well that will go onto our website for people to be able to see what the strategy is all about. The draft strategy is in an appendix at the end of the paper, but I'm happy to take any questions that you might have about it. Oh, I'll mute.
Dr. Felton, you're muted, Chair.
There we go. Dreadful. Oh, it's because I was going to cough. Ted, you're first.
Thank you. I'm going to do it. My question slightly Rosita style, but not as long. You'd be pleased to know. So everybody, stop laughing.
You are as long, Ted. You just haven't noticed.
So, okay. I mean, if what you're proposing is quite simply superb. Well, when you look, if you were to count the number of bullet points, this is absolutely outstanding. But to give you some background, I recently, this year, have taken part in 2 experiments at Loughborough University. I volunteer for them in their health and wellbeing department, doing various, volunteer exercises, and in both of them, it was quite marked how whenever they tested your weight and fat content and BMI, it was just so incredibly easy to be over, and their standards were so strict as to participation, and it brought home just how incredibly difficult it is to actually have a very healthy weight. And the thing I really want to push, and certainly in this consultation, is just it's understood that COVID takes precedent, but the amount of advertising and the messaging that's been brought home about that's been so successful. We did the same over a more prolonged period with smoking. How can we influence the government to do way more? Because with all of these great initiatives, unless we have a prolonged, almost to the level of the drink drive campaigns, that we constantly educate the population nationally about this, whilst we can get the amount of obesity down, we are dealing with a national problem. Low from the locality perspective, this is excellent, but we require way more public advertising to really tackle this problem. So that would be my first point, because you see, for example, we talk about we're providing, there was something about providing 35,000 healthy meals. That's great. We're doing all we can. But another national problem, which I can see you starting to address, and it's something that perhaps if we can have a little bit more information on, is things like fruit and vegetable vouchers. Because food poverty, to give you an example, a punnet of seedless grapes is average is £2.10. If you go to the Alges of this world, it's about £1.90. A packet of biscuits is about less than £1. So if you're on a low income, which one are you going to choose? So we can do all of these things, but unless we tackle what can we do in the face of commercial prices of fruit and vegetables and healthy food? So again, you see, we're dealing with national problems, and we're doing our very best to tackle them. They're the issues I see. We're up against a huge problem here.
Yep.
So, Liz, do you want to go first, or shall I?
I'll give you my answer, and then Mike can chip in as well. So I completely agree that there's actions that need to be taken at central kind of government, national level, and then actions that are taken at our level, at the regional, or at the in our locality, and then actions for individuals, and we want to support ultimately actions for individuals too. I think what we've tried to do here is focus on the things that we can do locally and across our partners, and we do include in that working with the retailers of food, so working with both the fast food outlets, and there have been some really successful stories of trying to work with them to reduce salt, fat and sugar in takeaway food, and also the supermarkets in trying to persuade them to not have front of store promotions of very high salt, fat, sugar type foods, and really have much more of a healthy food promotions where they do that. Of course, it is, you're working with the commercial sector and they know what sells. So that is the constant battle that we're going to face with obesity, that we are kind of fighting the commercial and the environmental kind of pressures with the choices, and in some cases not really choices, that individuals are making. So a simple example was supermarkets who signed up to not having sweets at the counter as you check out, significantly reduce the amount of last minute purchases of sweet foods, confectionery by families, because they remove them from that point of you're just at the till, you see those nice treats and you pick one up, and that is a really effective strategy to nudge people into not buying that, those extra calories that they didn't really need. So absolutely working with all the sectors is part of this strategy, but we are going to have to be realistic about the fact that it's a commercial market that we're working with. And obviously in Leicestershire, things like cheese and pork pies are also a draw in terms of our tourism. So we have to kind of take a balanced approach there in kind of promoting tourism and the economy, and that's good for jobs, against kind of our approaches for promoting healthy food. So it's not easy, and it's that's why this system is a whole system strategy. And I agree with you about the affordability of fresh food. Again, that is really difficult. We know that there are areas where there's just, we call them food deserts, where there's just nowhere that you can buy fresh food at a reasonable price, and it occupies a large proportion of your disposable income. And the same with food swamps. That's what we mean by that, is areas where all you can access is fast food outlets, and there is nothing that you can access that's kind of cheap enough, healthy. So we didn't put in there anything about upward kind of work with government. Of course, the fact that the Prime Minister did have a serious impact of COVID, COVID had a serious impact on him, and he did say, that he acknowledged that, we shouldn't be kind of overweight in later life because of these kinds of risks. And there has been a central strategy that's come out from government around obesity, and there are measures like not advertising fast food, which I think has been announced just recently. So there are some government central actions that are being taken, but I agree with you, you know, we do need to work where we can with national campaigns to promote those. Mike, do you want to add any more?
No, I couldn't put it better myself, and I think you're right. I mean, I sort of don't want to stray too much into sort of making any kind of party political comment, other than saying to recognise, as you did, that to some extent, I think that, you know, COVID has been a bit of a shock to the PM system, and he's probably more up for tackling obesity and taking direct action in a way that maybe a year ago it would have been slightly different. So, you know, everything does come back to COVID, unfortunately, at the moment, but I think it does give us an opportunity to go and shake up national policy as much as it does local.
Okay. Rosita, stop chewing your chocolate now.
Thank you. Right. Now, I agree, it's a good report, and I agree with all of the points made, but I am really concerned on one thing, because if you have, take Ted's analogy, a packet of biscuit or no fast food or whatever, that is more expensive than fresh fruit. Well, if you're addicted and if you like your chocolate, you pay whatever it is and you still find that chocolate. And I have got the access to fresh food. I have got the access, I cook, I eat, I know I'm overweight, but I still will seek out the chocolate. And especially, and this is what we've got to be mindful of, that we are all working from home now, we have less exercise, so instead of focusing on work, I go out there 3 times to have a cup of tea with a biscuit and a chocolate. So I think with this strategy and looking forward to home working, I think it is education and promoting physical health and whatever. So I'll get to my other point. It is very much, it worries me that, and you can answer that, it's the balance. On one hand, we are saying we do not want to see young children, teenager being having models, skinny models as role models, but then we keep forcing overweight, obesity, and a strategy down the throat. So we need to maintain a balance between healthy and underweight. And I wonder, because you see, as Ted just also said, the guidance of being healthy and obesity is so strict, it's almost ridiculous. If I were to have the BMI, I would fall off my feet, as I'm expected. So there is a reality. So my question is, how do we address that balance, not to, you know, take it that bit too far? And whilst I'm, as I just said, it is a choice to go for the chocolate, but the underlying issue, and it's not been addressed in the report, to me, and don't laugh, Ted, it is an addiction, because I don't smoke, I don't drink. So my addiction is sugar. And so, but I do not want to address that because I enjoy it, and that is with most people. So, but how do we address the issue of it having a mental connotation? You know, that hasn't been addressed, because an addiction, whether it's to drug or to alcohol or to chocolate, surely is an addiction that leads to a negative outcome. So, back over to you. Thank you.
So shall I do this? Well, first, a couple of comments from me, Liz, and I suppose just to pick up on BMI and achievability, and I guess I just want to push back on that one again, Liz. Do chip in. There is something for me about, we forget that body shape and body mass has just gone up over the years, and so particularly around childhood obesity. You know, we get this, I suppose, in terms of parents from letters from parents, is what would have been acceptable What we would have just all looked at and gone at a child 40 years ago and gone, that's normal. Nowadays, I think we go, they're probably one of the skinniest in the class. So I'm a little bit pushing back on the idea that the body shape that we've got now is normal, when the answer is historically it's not. So we do need to challenge that. And then in terms of addiction, it is a battle. It's like any addiction. We can offer services through weight management, substance misuse, alcohol and drugs, which are there to help people if they want to be helped. But you can't force people to go into the service. So at the end of the day, despite a lot of people thinking of public health is nanny statism, here we go again, we're there to help people that want to make the change, and we can educate them and we can try and coerce them and help them into those services. But at the end of the day, it is a matter for them that they want to give up the chocolate and eat healthily and reduce their weight. And that tends to be the way for any of our services. And to some extent, that's both the positive, because we do need people to buy into this, and the negative, which is we can't empower people to do it. But Liz, I don't know if you want to comment on that.
But should it then not be reflected within the strategy?
In what way?
Because if we recognise that it is also a mental issue, to reflect that within the strategy. But anyway, over to Liz.
Yeah, I mean, I think we. I agree. It probably hasn't come out really strongly in this draft strategy, and I think it is a really important point. This relationship between food and mental health, and we know, for example, in the very specialist services, for the services that are just the tier below bariatric surgery, having psychological support is a key part of that service, because there is such a tight relationship between food habits and the complexity with both addiction, but also with poor self-esteem and with self-confidence and self-efficacy to make changes. So I totally agree that it's mental health is an important part of it. And so we're not pretending that this is easy, but we, the services that we have in the county council, the services that we have in the CCG and the specialist hospital services do take account of the psychological needs of the people who come along to seek support. So, and I agree also that there is a fine balance with child self-esteem and trying to encourage children to be a healthy weight without them making them feel like it's their fault, or that they're kind of going to be really ill for the rest of their life. Our approach, the services we have for children's weight management, are very focused on being more active, of enjoying physical activity, of taking the emphasis away from their weight and more onto being active and having fun cooking healthy food as a family. And again, it's a very family kind of focused approach, as opposed to you need to put your child on a diet. It's we need to look at you as a family and support you to be able to buy and cook healthy food, and show that it can be done on an affordable budget as well, because some of it is about cookery skills, and that's part of the strategy. Some of it is about food banks and making sure that food banks, where they are needed, do supply healthy food, as well as some of the the less kind of healthy options. So there's just so many different facets, and you're picking up on those things, but they are all really important. I agree.
Thank you very much. David Bill. He's gone. David Bill, you still there?
Yeah. Good afternoon. Yes, sorry. Yes, I'm going to have to go in a minute. I'm afraid I've got yet another meeting, which brings me to one of the points I was going to raise, and that is, if we didn't have to spend so much time staring into these little screens all day long and could get out, and it is a serious point, just how much of the nation is now staring into a screen all day long until we've had enough, and then we switch on the box and stare into a slightly bigger screen. I mean, it's a point we've all become totally sedentary, and I find this so frustrating. I'm looking at Mike now to say, please, when can we start going out again and doing what we do as councillors, and that is visiting people?
Just to remind you, David, if we had been in a meeting at County Hall, what would we be doing? We'd be sitting, looking at each other.
I don't. I get up and I walk around and I go and do some work.
Well, I think things are different. I mean, I won't comment on when we can go back to going out and knocking on doors and canvassing for members. But actually, I mean, my personal reflection would be, despite the fact I've now been rooted to this chair since 8 o'clock this morning, particularly in the summer, I was able to get out and get a decent cycle ride for an hour in than I did last night. Whereas when I was working in County Hall, I used to have the same office hours, but I would have been in the car for 2 hours driving, and I'd probably been able to do more physical exercise and more work as well, whilst I've been working from home than when I used to be coming into County Hall more regularly. So I think the important thing, again, either COVID related or not, is to try and break up the day. It is important to try and have a bit of a stretch and get a bit of daylight, particularly in the winter, because working from home and then a bit like now, by the time you finish working, it's dark. We are going to go stark staring mad if we do that. So I would encourage everybody to, if you're working from home, break it up, have a break during the day, get outside for a bit, and just make certain that you put the commuting time to better use.
Yes, quite right. Anyway, David, you must have had a question.
Yes, there were a couple of other points. You watch the soaps.
No.
No, well, and if you look at them, they're nearly all based on a pub, or there tends to be a pub involved, and the amount of drinking that goes on, not just in the soaps, but in virtually all the plays and things you see on the box, they seem to be it's a continual thing. It makes you wonder how they can finish the program sober, but it can't be right, can it? And then all the flaming food programs, Bake Off and all the rest of it, which just it's a continual stream of what you should be doing now is eating more food or cooking more food, preparing more food, and then presumably eating more food. Everything that comes out of the box is pointing in the wrong direction. But that's just just observations. And Mike, could I just ask a serious point, if you like? Oh, probably not a serious point, but normally this time of the year, those of us who are county councillors staring into this screen here would be up and running up and down the streets, talking to people and all the rest of it, because we've got a May election coming up. Are we going to have May elections, or is the rest of the country going to be in lockdown, except for poor blind people trying to stand for re-election? Has there been any thought given to that at all?
Well, we've just had the American election. Although I gather the result is still not absolutely formal, a lot of that was being held up because of postal votes. Now then, how about if we all went over to postal voting because we couldn't go and vote at a polling station?
Yes.
There's your option.
Yes, but
I understand from what I've been speaking to a couple of people about it. Nick Ruston in particular has been asking the question as well. And he's been told, and that's in the last couple of weeks, that at the moment the May the 6th election is still absolutely on.
So how on earth can you have an election when you're stuck at home and not allowed to leave your house? I just don't understand.
We have the 2nd of December.
Two bits. There's two bits to that, I suppose, just to come in. So, in terms of whether the elections go ahead next year or not, is obviously not my say so. Clearly, it's the conspiracy theory which would suggest that COVID is being spread by people to undermine our democratic institutions and take away, which is obviously the truth,
Yeah.
But actually, if you're asking me to second guess what will happen in terms of our ability to get out and for members to canvass next year in the elections to take place, I would like to think with what's going on around vaccine development, testing development, we'd be in a better place. And even before then, as I've said before in meetings, if not in scrutiny, you've heard the CMO say that come March, April time next year, we will be in a much better place, if only because the seasons are with us and people are more able to get outside. So I would still be hopeful, pride comes before a fall, that we'd be in a position that elections could take place and members could get out on the street, canvass and leaflet, at least in some way, shape or form, like they would have done anyway.
Okay.
But I suppose, there you go, 50 quid donation to charity if I've got it wrong, and elections don't take place in May next year.
Okay.
No,
this is a
that's all except the Hollycroft division, of course.
And I do give it everything, all the support I can. I can see youngsters are getting bigger and bigger, and it's frightening. So everything that we can do to support this has to be done.
Yeah,
anyway, with that, can I love you and leave you, because
yes, very much. Thank you, David.
Yes.
Go back to Hollycroft and go and start talking to your constituents.
No, I've got another Zoom meeting going. I wish I could.
Amanda.
Okay. Amanda. Good night, everybody. Bye.
Bye.
Yeah, Amanda. Sorry, Amanda. Yeah. Yeah, you keep coming and going.
Sorry, we're talking about the weight management strategy, aren't we?
We are.
Yeah, that's fine. I thought I'd gone into a different meeting there. Just a couple of points, actually. First, on the healthy weight information, the nearly 2/3 of adults, 62% were classed as being overweight or obese. Where does that data come from? We're really interested to understand that, because obviously when you go to the exercise information, I think one of the things that you can obviously see from the people who are exercising, those who are exercising regularly. Yeah. And those that are not are generally not, and the ones in the middle are very, very small. So those that they're only exercising for up to 150 minutes a week. There's only a small amount in that bundle. So I'd be really interested to understand, because I'm part of a running club, a really active running club, and we're all of different shapes and sizes. I would guarantee you some of our runners that are running 25 miles a week are still within the categories of being overweight. So I suppose what I'm interested in is how do we get across that actually exercise is only part of the solution. It's actually eating that's the biggest point. I mean, certainly if you were to do something like Slimming World, exercise is not even part of their program. It's a very small part of their program. It's eating, and eating is their sort of big thing. The question I had really was about how do we balance healthy weight? Because a lot of this is around obesity. And I think with the current situation we're in around COVID, is there are certainly going to be two groups. There are going to be individuals who are starting to become food poor very quickly. And how do we ensure that people are getting the right food and nutritional food that will give them enough to sustain? And I think one of the things that's always very difficult is particularly those who would identify as being themselves in food poverty. Actually, it's calories over content, which is generally the driver. So as Ted says, completely agree with Ted, a packet of Bourne biscuits is 37 pence in Aldi, and fruit is cheap in Aldi's, but for if a packet of biscuits, 2,000 calories, you're not going to get 2,000 calories of healthy food for 37 pence, no matter how hard you try. So it's actually how do you balance that, but also understanding nutrition and malnutrition and the impact that has on society, and how can we do that. I'd be really interested to see within a healthy weight strategy that we consider the impact of people not eating enough, as well as those that are eating too much. The other thing that I just wanted to raise really quickly is I think it came through in Mike's report last year, just about access to activity. And I think one of the things that I'm really concerned about is actually those individuals that would be deemed as being unhealthy. How easy is it for them to access facilities? And certainly the impact active travel, the impact of green spaces, of which we are seeing reductions in green spaces. We have to recognise that, and actually how parks and green spaces are owned just by certain groups of people. And for example, I run regularly, but there are places I won't run. One, because it's too scary that it's not lit well, but two, because I see those spaces already been owned by boys and men because they're football pitches. So it's actually how do we encourage active people to be active and own spaces and take spaces back, really. Thank you.
Shall I start, Mike?
Yeah, go on then.
So on the first one about the data, so there are various surveys that are undertaken nationally to look at both healthy lifestyles, but also physical activity. And so the data that we've presented in there is from the Public Health Outcomes Framework, but that in turn has been taken from Healthy Lives Survey and from Active People's Survey. So they're national kind of validated surveys that sample across sample of the population, and they oversample certain groups to make sure that there's representation. So that's not from our own county council's local data. It is from these national surveys. The National Institute for Health and Care Excellence guidance on weight management is that you shouldn't use physical activity in of itself to lose weight, that what you have to do is reduce calorie intake. So that has to be the kind of primary focus. If you want to lose weight, you have to reduce your calorie intake. Sure, you know, it's kind of calories in, calories out, energy balance, but actually to lose weight, you need that calorie deficit. And so being active is really good for your health, and it probably has other additional benefits, even if it isn't impacting on your weight. And that is why physical activity is part of this strategy. There's not a huge emphasis on it in this draft because our active partnership, Leicestershire and Rutland Sport, are leading the, if you like, it's a bit of a Venn diagram. They're leading on the physical activity strategy. We don't need to duplicate that. We'll absolutely tie into it. We're bought into it. They're hosted by the County Council. We work with them to develop that strategy. So the two, the kind of weight, nutrition, physical activity are absolutely tied together. So that's really important. And in terms of providing opportunities for people to be active, I agree with you that, you know, things like the environment, whether it's well lit, whether it feels safe, are all going to impact on people's, you know, perception of whether or not they should and want to be outside. But we do want to encourage people to be outside. So part of our exercise on referral program, which is where if you go to your GP and they think that you would benefit from being more active, which to be honest is most people, but if you have a health condition, they can refer patients to this scheme, and we're working with our providers of that scheme to provide more outdoor opportunities rather than just focusing on circuits in a gym, which don't appeal to everybody. So it's having that breadth of offer so that you can appeal to different people. Nationally, Sport England have done a lot of work around campaigns to encourage women, for example, to exercise more. We know that older women, well, women in their sort of 20s onwards really do less activity than men. This Girl Can campaign is an example where they've really tried to show the kind of warts and all of kind of sweaty women, different shapes, sizes, doing, you know, kind of lifting your baby because you're not, you know, rather than doing circuits in a gym, you know, all sorts of different ways of appealing to women to be more active. So there's so many different facets to this, but a lot of our work on physical activity is looking at minority groups and ways of encouraging inactive people to do some activity, so that nothing to something is the greatest health benefit. And a lot of our work at the moment is focused on that nothing to something. So Couch to 5K is a great example of an app that takes you from never running to being able to do 5K, and hopefully then you carry it on. The food poverty is a problem, and at the moment with you know, families, you know, with job insecurity and uncertainty with the pandemic, I think that is a real concern, and that's why we put the bid into for the National Holiday Hunger Scheme last year, which we've referenced in this. That was really successful, and it was to provide both food and physical activity opportunities for children during the summer holidays. And that went really well. We also have funding from Sport England for an active families programme, and that's families in Leicestershire who have totally disengaged from lots of services and have, you know, maybe have lots of problems with antisocial behaviour or complex kind of family problems, and we work with them to encourage them to be more active and using, you know, the outdoors where they don't have to pay for it, they don't need equipment necessarily to kind of enjoy being active, and really trying to focus on those opportunities. I agree that malnutrition, we should probably look at that, how we increase the prominence of that in the strategy, particularly for older adults. That is a real problem. And hospital food and malnutrition is a problem, and you know, we're going to be working with UHL to look at the hospital food provision. Sorry, working from home, I think my dog's going to walk in now. And then also when looking at the food deserts, and as I said, the food banks, and looking at how we encourage people who really have very little access to healthy food in their area, access that. So again, it's kind of multi-pronged, many sort of facets to the strategy, lots of work to do. This strategy is about, have we got it right? Have we got the kind of balance right? And I think you've raised some really important points there.
Thank you very much.
No, nothing further for me, other to note that you've got a very, very clever dog.
Did you shut the door as well?
Yes, great.
Like,
and
Thank you, Liz.
Thank you, Chair. My dog's asleep. taking over the settee in my absence. There's some really interesting stuff come out this afternoon. I think what Ted was saying about changing social attitudes is a big thing. And I think this, you talk about exercise and access to food. I actually, with exercise, some people, 5K is too much to ask. You should just encourage people to walk everywhere. I see people drive cars ridiculously short distances, which is bad for them, bad for the environment, and frankly, a pain in the butt. Sometimes I'm quite a militant pedestrian. I think that needs pushing more. Personally, it's a personal thing I've got. I do like your point in the report about an osmogenic, wonderful word, environment. And I think this whole thing about fast foods, and particularly for school kids, it's too easy to go and get a takeaway or buy the biscuits or whatever. I mean, a friend of mine worked in the food industry, and he said the 2 cheapest ingredients are salt and refined flour, which tells you everything you need to know about the food we eat now. So what I was driving at really is, how are we going to engage with the likes of districts and others to perhaps change the planning system to make some of these access to food more difficult? Because there's certainly places in some of the towns where, every other outlet is trying to flog you unhealthy food. Not all of them, but a lot. So that's all I wanted to say. Thank you, Chair.
Again, that's something that we want to kind of look at. So working with environmental health, working with trading standards, those partners who kind of have some of the influence in those sort of sectors, that we can look at what's available locally. We know that having fast food outlets close to school increases the likelihood of children using them. So, that's the kind of thing that is included in there.
And it's the first strategic objective, isn't it? Basically, a obesogenic environment, isn't just about physically, the physical activity infrastructure. It is also about tackling the kind of one that just encourages, in the way that you've described, fast food outlets and everything else.
Yeah. I blame those, the brown fat cells in my back, that I was fed lots of fatty things when I was a child, and they just blew up. But obesogenic, new word I've learned today. Right, I'll put that in my list following lockdown. Thank you very much. And Harsha from Health Watch, have you got a question?
It's not necessarily a question, but a bit of a comment. We've talked about the weight management strategy and obesity and all this, but at Health Watch we have people telling us there's nothing for the system's not providing for us because we fall between. Our BMI isn't enough for us to access lifestyle services or whatever, and they're not underweight or anything like that. They're in that category where they're going in the wrong direction. They want some support and help to make sure they don't get in the wrong direction, but there isn't anything available to them. So I wonder, is there something that can be put into the strategy that allows for people to access things from health or the local authority, social services, that allows something to be done within the prevention agenda, so that you don't get to a point where your BMI is such that you're classed as obese and things like that. So you're starting to look at things that enable you to get out there and exercise and start running, and it may be just to start walking because 5K is too much, but more around the prevention so that we're not into the realms of obesity.
Yeah, so the in terms of that probably the overweight category might be what you're referring to there. So typically, weight management services, lifestyle services, and then obviously the more specialist services in the hospital will be the higher the BMI, the more likely you are to qualify for those. And there's a band there between the kind of overweight and the obese, the BMI range that's just above that, where often you don't qualify for actual, weight management counsellor or psychologist or that kind of support, but you do need some support to just nip it back and get it back to weight. And that's really the tier where we're trying to focus on. Kind of what the commercial market can offer, but also what supported self-help there can be, because there are some really good products. The NHS website, for example, around kind of setting goals and monitoring your weight. So they're supported self-help, but I agree. When we're in a system where we have to, there isn't an unlimited pot of money, we have to prioritise. But Yeah, I get that.
I understand that, but it just seems to me that people are telling us that it's almost as if they're saying they need to get overweight to be able to access stuff, and we shouldn't have a system that is forcing people to get more weight on them just so that they can get free access to lifestyle services, so they can bring it back under control. Surely there must.
Sorry, Harsha, just to come in. I mean, the whole point of the strategy and the objectives around the obesogenic environment is exactly that. I mean, it is by and large a preventative strategy to try and help people maintain a healthy weight. The point about access to services, if you get to a certain level, is well made, but that is an issue of funding. So I think both philosophically and money wise, that's exactly. I think we're with you, and I've not seen anything within the strategy which suggests it's a strategy for people that that would make people put on weight to access the services which we do provide. And I should say we still provide them where lots of other places have cut them totally.
Yeah, I'm not saying that you are. I'm just saying that this is what people are telling us, that they feel like they've almost got to put the weight on to be able to access it, and we need to make sure that people are aware that that's not the case.
Yeah.
Right. Yeah. Very good. Thanks, Harsha. Yeah. I mean, the only point I made it earlier today is, I mean, I've lost now 5 stone from the 18 stone I was about 2 years ago. And the biggest disadvantage, I mean, fine, I have to buy new clothes, all that lot. I'm chucking out so many big clothes, but I've lost muscle. I'm no longer able to lift things that I was able to because I didn't do any active stuff at the same time. I basically just ate less, did a bit of walking, but not much, and forgot about the fact that I have muscles in my arms, or used to have, and now I'm having to build them up again. A lot of the weight clearly has not gone from the fat globules, but actually, or the lipids, it's actually probably gone from the muscle.
I mean,
I wasn't aware of that.
It is quite normal to lose muscle mass with age. That is a normal process.
I appreciate that. But nevertheless, it's quite dramatic.
It is. And we do have physical activity programs that are specifically targeted at trying to build that muscle mass back up. Not particularly after weight loss, but we have a program, you might have heard of it, called Steady Steps, which is about building muscle mass, bone density, and improving your balance, and it's targeted at people of a certain age.
Indeed so. Yes, I must. Now my family are all going to buy me dumbbells, I think, for birthday present.
It's really important to maintain your weight-bearing exercise. Absolutely.
Yeah, but no, I know what you mean. Actually, I keep thinking my feet are too small. Yeah. Anyway, that's lovely. Thank you very much indeed, Liz. That was really helpful. Hopefully, you've got a few pointers there from those that are left on this meeting. Mike, I've got you down for giving us a presentation on, presumably to do with, maybe something to do with COVID. I don't know.
Could be. Yeah. Right. So I'm aware it's after 4 o'clock.
It is, yeah.
And those members of the Scrutiny Committee that were on the all-member briefing yesterday, I don't want them to feel
that's right, they've gone.
That 4 o'clock is a bit of a groundhog day when I turn up and start talking about the numbers. So I'm not going to do a huge presentation. I was going to just do a verbal one, but I've just done one slide, which hopefully is just about readable. But I'll just talk you through it. So main bits from me, just in terms of COVID, and again, for those people that were on yesterday, you will have heard me say this before. Where are we? Good bits and bad bits. So what you've got in the third column is the case rate per 100,000 population of COVID-19 within Leicestershire, and I'll put Leicester and Rutland in just for comparison. May as well start with the bad bit. Whenever it was the last time we met as a Scrutiny Committee, the rates will be just so much higher than they are. So the average today in Leicestershire is about 290 cases across the whole county per 100,000 population. And if you think about the end of August, just going into August bank holiday, the rate in Leicestershire was below 10. So when we talk about things being up and being down, there is something about bearing in mind how much that has changed in less than 3 months. But as you can see there, essentially there's a bit of a pattern. We would have talked in the past around hotspots, like Opium Wigston would be the obvious one. Whereas if you think of the average, as I say, in Leicestershire being 290, yes, it's less than Leicester, but we've got everywhere in Leicestershire now above 200. And then on top of that, rising tide, and it's not a tide that's lapping around our ankles. It's up around the waist. You've then got additional cases in still places like Blaby, Oby, Wigston, and Charnwood. Some areas have gone down a bit. Notably, those ones have been a bit higher over the last few months, Charnwood and Oby and Wigston. But that's been at the expense geographically of more marked increases lately in Northwest Leicestershire and Melton in particular. 17 to 21-year-olds, obviously, we've talked about issues to the student population in Charnwood, but actually for some time, as you can see there, rates across the board in the 17 to 21-year-olds have been significantly higher than the population as a whole. But what we're seeing at the moment is a sort of fairly stable rate across the county, driven by decreases in some geographies, increase in others, but also largely a decrease in the 17 to 21-year-old population, the younger population, but largely made up by increases in older age groups. So not just middle age, but particularly, as you can see there, increases in the over 60s. And it is not too many weeks ago, probably only about 3, that the average in the case rate per 100,000 population in the over 60s was about 60. And now, as you can see there, it's pretty much above 200 in all bar Harborough and Hinckley and Bosworth. And the important thing really is case rates in the over 60s are pretty strongly associated with increasing hospital admissions. So when you look at the headline figures, and I can say, things have stabilised in the last few days, even then, I think that massive change in the age distribution of cases and will have a knock-on impact on the health service. So that's the picture from me. Couple of other bits to maybe mention is, again, I've said at other briefings, we definitely saw a bit of a spike in cases on November the 2nd across Leicester and Leicestershire, and indeed the country as a whole. I have a feeling that that was triggered by people getting a test on the Monday after the PM's announcement of the second lockdown on the Saturday, a week last Saturday, which probably is an indication that there was a proportion of people who until then may well have had symptoms, but they were mild symptoms, and they were resisting getting a test, partly because they maybe thought that testing wasn't available, which it is, but maybe also because they were scared about getting a positive result and having to go into self-isolation. So the peak on the Monday the 2nd worries me, just in case that actually say there's a good 10 or 20% of cases which we're not picking up because people aren't getting tested, and I would urge people with symptoms to do the right thing and get tested. And then equally, I do need to look a bit more closely at this one, but I've got a feeling that yesterday we had a bit of a spike come through in the testing as well, which, if that was 4, 5, 6 days after the start of national lockdown, I hope but fear may be related to the inevitable outcome of the last hurrah that people did with their shopping and their socialising on the early part of last week through until Wednesday. All of which is we do need to get ourselves down to as low a position as we can throughout Leicestershire in advance of December the 2nd, so we can come out in the lowest tier possible. But I suspect the answer is case rates won't go down for a little while yet, just because of the way numbers have bubbled up over the last week. And probably even more importantly, that inevitably, because of the time lag involved in this, that we're likely to see hospital admissions and unfortunately deaths rise in the immediate future. So a very brief summary from me, just building what I normally say.
Thanks, Mike. Yes, I think I saw somewhere today on social media the number of deaths now has gone well over 50,000 for the country. And I remember it was 50,000 before, and getting back to Ted's question ages ago, that's when they weren't counting these deaths within 28 days of a COVID test. It does show you, doesn't it, though? We're back more or less where we were, but actually lots more. No, very worrying. I mean, I think I can understand now a little bit, I think, why we had the Prime Minister talking to us earlier this week on the announcement of the vaccine and Jonathan Van Tam, because quite clearly they're panicking that people are just going to say, it's fine, don't worry about it. We can just go out and do what we like. It's still got to be under control, and it's way off that, isn't it?
Everybody always wants a silver bullet, and I can understand it, but we will get a vaccine. It won't be tomorrow. We will get mass testing, but that won't be tomorrow. But by Christmas, things will look different. But we all just need to hang on in there for now.
We do. And I mean, you may have noticed I'm actually not growing my beard this year. I normally do at this time of year because I get called on on Christmas Eve to do all sorts of things and wear my red costume. It's not going to happen this year. Amanda, you've asked you a question.
It was just a very quick question, just to see whether or not we'd started to get any information coming through on the state of play in terms of Leicestershire population for long COVID, and what the long-term implications of that is going to be. And my understanding also is that people who have had COVID, there's a higher incident than starting to struggle with mental health conditions. And I don't know if that's connected to lockdown or the worry or whatever but I didn't know what was coming out of long COVID.
Yeah, locally, nothing much statistics wise yet. I will pick up with health service colleagues. We obviously got a few good. We've got a few stories, which are bad stories, but are very useful to start flagging up from people who've been suffering the effects of long COVID. And you start seeing those in the local and national press. But what I haven't got is stats that say that X% of people who've had COVID have gone on to then develop long COVID. But I will look into that one for sure.
Yeah, I wasn't sure whether it more linked to people a bit younger than the 60s, so to speak.
Yeah, I mean,
so to speak. It has appeared in over 60s because a lot of them sadly have died.
Well, I mean, and I was going to say that's the focus. I do get a number of emails, and indeed when I've done interviews with the Leicester Mercury, you get the comments, what's the average age of death? Because I think with most people now, the average age of death is 82. Yes. So the average age of a hospital admission is 58. So, there is and I think you can see that to some extent playing out with the second wave. Yeah. But it seems to me that however scary the 50,000 figure is, this time round, touch wood, mercifully, we haven't had as many deaths as before. Partly, I think that's better treatment. Partly, tragically, I think that those that were going to be taken by COVID the first time round have gone. And, if there's one thing in life, you can only die once. Sean Connery's next film. This time round with the second wave, then I think it's going to be different. And actually the focus might well be on less on deaths, but more on admissions and the long-term effects.
Quite, yeah, absolutely. Ted.
Yeah, that was the point that Amanda said about mental health, because when we had the nurses on earlier on, and the lady was talking about she hadn't got the IAPT figures.
Yeah.
That was a shame, because of course that would give you an indication of how many people were suffering from mental health, not necessarily obviously in relation to what Amanda was saying specifically to COVID, or maybe they've been given a positive diagnosis of COVID, but just people generally that were accessing mental health services. Can we do anything we can to make sure we do get those figures for the next meeting, please?
Yeah, we'll do.
Yeah, thanks very much, Ted. Yeah, fine. Well, you've got away lightly, probably because they're diminishing the numbers on this meeting. They keep going off to other meetings. But thank you very much again, Mike, and obviously Liz earlier. The next item is purely to confirm the dates of the next meetings of this austere committee, which are due to take place at 2:00 on the 13th of January, 18th of March, and then depending on how many of us get re-elected, the 2nd of June, the 1st of September, and the 10th of November. So put them in your diaries. I've had, as I said earlier, I've had no items for urgent approach. So at 23 minutes past 4, which is 23 minutes later than I was assuring people we'd finish, but I'm blaming a certain Mrs. Page. It's all her fault. Thank you very much for everyone for joining us. A lot more information we've had today.
Thank you very much to everyone.
We'll see you all soon, I'm sure. Yeah. Thanks very much.
Bye-bye. Bye-bye.
Thanks, Chair. Cheers. Take care, everyone. Bye-bye.